So I'm Nora Al-Haj. I'm a attending physician in pediatric hematology and oncology at UMass Memorial Medical Center in Worcester and in Massachusetts, if you don't know where that is. One of my interests is sickle cell disease, and I'm very excited to talk about the use of virtual reality in pain management, particularly in the context of sickle cell disease and our pediatric patients with this disease. I work very closely with our child life specialist, and Nicole Nolan couldn't be here, but I love working with her, collaborating with her. Huge shout out to her. She's helped so much with this project. So I really appreciate the help. So to get going, it lets me advance my slides. So just to get oriented a little bit about what I wanted to get across. So I think it's really important to understand, if you have no background in medicine, just what is the patient population we're talking about, and really what this disease is and how it manifests really. And then, you all pretty much may be familiar. We've had talks about this in the past, but just how VR can be sort of leveraged and used in a pediatric healthcare setting. Other great talks, I won't be spending a whole lot of time on this, but really what I want to talk about is also how we implemented some pain management strategies with the use of virtual reality at UMass in particular. So as I said, really important for us to get a sense of who are our patients, what is this disease, what are we doing, and why do we do it? So just wanted to orient you and give you some context. So, patients with sickle cell disease, this is an inherited blood disorder. How many people have this? Actually, the National Heart, Lung, and Blood Institute will say 20 million people worldwide are affected by this disease. We used to say 300,000 born each year, but that was really old data. When we look at some more recent data, we're thinking more 500,000. The reason why we're not so sure and that trends are very approximate is not everyone, not every country, not every region in the world necessarily tests for this. We do in Massachusetts, so it comes off on the newborn screen. So people might not know their carrier status. In the United States, we have very, very old data that we've been using for years and years, saying 100,000 people. But that's from almost 15 years ago now. What we do see is there's some really hot spots for sickle cell disease: sub-Saharan Africa, India, the Middle East, Central, South America. Why is that the case? Well, actually, if you're a carrier of traits, this might be protective against malaria. So sickle cell disease, your red blood cells are shaped abnormally. And that means that the malaria parasite can't get into it as easily. So protective against malaria, but if you have a lot of people that have trait, which is carrier, and have children together, you increase your chances of having a child with sickle cell disease. Very important from an equity, a health equity, and a diversity standpoint is majority of our patients are patients of color. 90% are non-Hispanic, Blacks, or African American. 3 to 9% are Hispanics, flex minorities. So as I said, this is an inherited blood disorder. So that means you have one change in your genetics that causes a protein in hemoglobin to basically be abnormal. Hemoglobin carries oxygen. Hemoglobin is in red blood cells, a component of our blood. So that causes our normal shaped red blood cells to basically sickle. And that sickle is called sickle because of its shape, but it's also a crescent. So this seems complicated, but it's not that complicated. So your cells sickle. When they're this shape, they tend to cluster together and form basically blockages in your blood vessel. When we talk about the sickling process, this is called hemoglobin polymerization. You don't need to know anything about that. But basically, when these cells cluster together, the blood flow through those blood vessels doesn't go as easily. So it's kind of like a traffic jam, except of being just like annoying in traffic, it can just cause a lot of pain in different areas. This is what we call vaso-occlusion. There's other processes that are involved, not just sickling. There's a lot of inflammation and the fact that the blood vessels don't function as well in terms of their lining, but that's kind of the main spot. I talk a lot, but I figured I would share a video to kind of explain this in a more
Sickle cell disease is an inherited blood disorder that affects red blood cells. Healthy red blood cells are round and flexible, allowing them to move easily throughout the body to deliver oxygen. Red blood cells contain hemoglobin, a protein that carries oxygen from the lungs to all the tissues in the body. However, people with sickle cell disease inherit a faulty beta globin gene, referred to as the HBB gene, that affects hemoglobin production, causing the red blood cells to become stiff and rigid and take on a sickle or crescent shape. The sickled blood cells break apart easily, causing inflammation and damage to the blood vessels. When the blood cells clump together, this stops them from moving smoothly through the bloodstream. As a result, they get stuck in small blood vessels and deprive tissues and organs of the oxygen they need to function. This causes fatigue, pain crises, and silent damage, and can lead to complications, including infections, organ damage, stroke, and in some cases, premature death. Sickle cell disease greatly impacts a person's everyday life, since it can be difficult to manage and may require frequent hospital visits.
So I cut it kind of early because we don't need to hear about treatments, et cetera, right now. But I think the big point is a lot of patients are hospitalized quite a bit, and it's quite a painful condition. So pain is a hallmark of the disease. And that's really what brought me to kind of think through this project and think through pain. So pain is actually can be triggered by a lot of different aspects. So we call acute pain, or these acute episodes, vaso-occlusive episodes, are the number one reason why our patients come to the emergency department or are hospitalized. That can be triggered by things like stress, temperature, like really cold temperatures, really hot temperatures, dehydration. Living in Massachusetts, I mean, the winters are not kind to our patients. Infection, activity, strenuous activity, all of that can impact pain. And over time, you can also have these chronic pain patterns. And your brain and your central nervous system and your peripheral nervous system can be sort of sensitized towards that. Chronic pain is quite difficult to manage and also different than acute pain, but that can be modulated by anxiety, depression, sleep, stress disorders. All of that can make pain much worse. And we have to think about that when we do pain management. So a lot of my patients feel like when they come sometimes to the emergency department or to the hospital, they feel like they are not necessarily heard. And part of that is because, one, the major way we treat acute pain episodes is opioids. We talk about the opioid epidemic all the time, but for our patients with sickle cell disease, they sometimes do really need those opioids. This is an article from the New York Times, but some children even think that they would come to the hospital and feel like doctors feel like they're seeking drugs or they're drug seeking behavior. So the terminology can be quite hurtful. And they are really used to living in pain in some ways. And when they are on their phones or they're distracted, that those are coping mechanisms for a lot of our patients. But it feels to some providers that maybe they don't take pain scores seriously and their pain is often undertreated. If we compare to patients that come to the hospital with fractures, those are treated much more rapidly, promptly. So again, when we think about our diversity, equity, and kind of some of the racial bias and systemic bias that we have sometimes in our institution, that plays a big role. So my job was trying to think a little bit through that and think about what I do in Worcester and how to support our patients, and just think about presenting to you guys just a local perspective and thinking about how we leverage technology. So this is where we are. You can see around us, we have quite a few sickle cell treatment centers that are either whole life or just pediatric only or adults, but we are surrounded by much greater, bigger institutions. But, you know, our numbers are there, and we really want to serve our community. And I came from California. Before I came here, I was in Oakland. So different landscape, but important to serve our community, and our community is growing. So these are a number of patients basically from 2018 all the way to 2023, and we've clearly doubled our numbers. And part of that is because we're a refugee resettlement area, and we're seeing a lot of migration trends. So if you think back about what I was explaining earlier about trends, where do people with sickle cell disease live? Migration has changed that a lot, but we are seeing some refugees, and we're seeing more patients, and we're seeing more people with sickle cell disease in our program at UMass. So when I thought about what I'm going to do about this, so obviously there's always opportunities and challenges. And what we want to do is find some options and some alternatives, and also grow this and scale this. So you start with an idea. So, you know, for me, we'll talk about the idea of VR kind of came from Oakland and my experience there with Kind VR, and then kind of test it in your environment and make a case for its use, implement that intervention, and then we want to scale it. So here we are. So as I said, you know, I came from a pretty big legacy center in Oakland, California, one of the first sickle cell centers in the country. Very fortunate to have been there, and really think Simon Robertson, have a slide with him in a second, but you know, for all his help in bringing this technology to us, because that's really where I learned more about sickle cell pain management and the role of virtual reality there. And really, we are very thankful for this partnership. You know, our question was really, can we implement this? And we know it's been implemented in different clinical settings. Great talk a couple years ago when I didn't have to be on screen being like, I don't know how to put my screen on and I can't hear your audio. But, you know, I am happy to be here today and looking back, and I'm very thankful for Simon's work, and I'm really looking forward to his talk also tomorrow, and quite a few talks that are looking at pain management with VR too. But that's kind of how this idea came, is I had that experience in Oakland and then wanted to bring it to our center here and help our patient population here. So, you know, how did we even think about like VR too for pain? So VR can stimulate many areas of the brain that also help process pain. So if you're looking at this picture of a functional MRI, there's looking at areas that are kind of like lighting up, and your first column all the way to the left is basically your control. We're not using virtual reality, and we're not using opioids. Like, remember I said opioids is, you know, our standard of care for acute pain management in sickle cell disease. If you look at your second column, this is just virtual reality alone. And then your third one is virtual reality, no virtual reality, but just opioid alone. So, you know, the middle is either or, and then the last one is both of them together. And what we see is just basically alone, both VR and opioids appear to attenuate pain-related activity in the brain. And the combination even further reduces this pain activity. So that's actually, like, from a biology standpoint, and people that are all sciencey and trying to not be too much of a nerd like me, but, you know, I'm a hematologist, this is what I do. So, you know, there's some data around using that. And of course, you know, our partner, CanVR, like lots published, lots of ongoing trials, different hospitals. I'm hoping that at some point when we gather a little bit more data that we can be part of these institutions too, like mentioned, but lots of work. And I'm not going to talk too much about that because there's been other talks and will be other talks. But I think the big thing is you can leverage VR in different areas of a hospital. Like, it can be port access. Like, I'm also an oncologist, so that really helps. Peripheral access labs, some procedural interventions. Our colleagues in dermatology, we started talking to them about our experience with sickle cell. So they've started using it as well. But of course, in orange, this is what I do. So pain management, sickle cell disease, as I said, Oakland, other St. Jude's, other organizations, and we're bringing it here. So this brings me a little bit to what our work is like. And again, big shout out to Nicole. Nicole's here giving you a thumbs up. But our question was really, can a single VR session improve the experience of pain in pediatric and young adult patients with sickle cell disease? So we had a period where we went through the IRB, we had a period of some slower enrollment. And that's because a lot of our staff, we had some issues with staffing in our division. So, sometimes starting a study can be a little bit research intensive. So we had recruited about 11 patients, and it's been slow, but I'm hopeful that we can definitely continue. And this is really a pilot study. So when you think back to when I was talking about scaling ideas and just making the case for your intervention, it really starts with like smaller numbers and then you grow that. So we excluded non-English speaking patients, or patients with a history of seizure, facial scalp infection, blindness, or developmental delays. So we wanted them to be able to interact with like our hardware and our software through also some infection control strategies. And might you say, why would you exclude non-English speaking patients? Well, the reason for that is one of our pain scores, and I'll show you a picture, like requires the sheet in itself is in English. So we wanted to capture this multimodal pain approach without language barriers or without issues with interpretation. And that might change in the future if we get this tool translated in much more languages. It does exist in Spanish, but it was a little bit of a challenge. So just think about that. This does not do anything justice. But just wanted to give you like a sense of the hardware software. You've probably seen it before. I was trying to get you guys like a video of a patient doing it. We were a little bit short on time and just like the consent crunch there. But there's different in-kind VR. You can choose kind of your environment. A lot of our patients do choose the kind of the meditation, mostly aqua too. So you basically have a sense. This is just a picture and it's doesn't do anything justice, but just this is kind of what we've used for our experience here. So I talked about, our tools and how we're going to assess pain. So just to run you through what the process is like with this intervention. So we get consent, and then we do pre-session questionnaires, and then we make sure that we do some infection control. We do our VR session 15 minutes, and then we get some post-session questionnaires. So we use some Likert scales at first, but the big, what to take home from this is, what are we doing? So you want to evaluate pain scores and assess that pain, but also if you think back about modulators of pain, evaluate level of comfort and anxiety and trust in the treatment and trust in the treatment team. We also wanted to evaluate for potential side effects, especially when we're running this through the IRB, where they'll be like, well, Oculus, for example, makes a lot of people really dizzy. Like, is that safe in a hospital environment? So it's really nice to have also something designed within a clinical context too. And then we also did a post-session satisfaction survey. So the Likert scales are pretty straightforward. It's just kind of like from a scale to 1 to 10, this is how my pain is. This is how comfortable I feel. This is like my level of worry. Like, lots of patients actually are pretty concerned about their pain and they're worried about it. And they might not also feel that it's adequately treated. I talked a little bit about bias in healthcare and just sickle cell in general, and just the distrust that sometimes comes with that. And that's also sometimes something to think about, like, do they even feel like they can come to the hospital, and do they feel like they're going to be like heard and have pain management like strategies that are appropriate? And of course, it's always still standard of care to use medications though. So that's kind of like the basic Likert scale. Then this is really the tool that I was talking about that does involve some words and some language. So this is called the Adolescent Pediatric Pain Tool. It's a validated instrument, and what's nice about it is that it's very multi-dimensional way of assessing pain. So you can assess first pain location, like tell me on this drawing, circle areas where you're having pain. And that's kind of like location wise. And then when you think more about pain intensity is, can we have a patient qualify that in other ways that are not just like 1 to 10? So they'll actually have a scale that with like has no numbers and just has like these words, and they'll put like a bar somewhere in there, and then we measure that with a ruler, and we can kind of say like, okay, this is actually equal to a 2 or an 8. So it kind of is like more of like a visual and not just give me a number, and it's also a little bit different from like the FACES pain scores. And this is like the key point here. Lastly, looking at words to describe pain, and words to describe pain help us because they're kind of this multimodal approach. So it can be categories like sensory, like kind of like a character of the pain, but also can be temporal, like how does that like pain maybe like change over time? How do you feel about like the temporal nature of it? And how do you evaluate that and appraise your pain cognitively speaking? So that's like this evaluative thing, this evaluative category. And then you get a total score out of like these 67 descriptors. So there's like ways of scoring this sheet. It's actually really helpful to kind of assess, like, it's not just like, oh, my pain went from like a 10 to an 8. Like, what does that mean for you and for your experience? So what we really found is that we saw some trends that noted some improvement in multidimensional pain scores, but really statistically in the sensory pain category. So pain intensity, and this is like reported in medians values, but your pain intensity decreased and that was statistically significant. But we noted like a significant improvement in like the sensory scores in particular. So that's something that's interesting. And then I just wanted to show you a little bit more visual data. So overall trends. So the pre is the dark blue navy, and then the Carolina blue is this post-session scores. So trends showed that there was there's an improvement in these like multidimensional scores, and I said statistically significant in sensory pain. Overall, people did quite well with quite some decreases across the board, but wanted to look at that data in a little bit more detail in a patient-specific way. So you'll see some patients actually did well across the board in their scores. There are a couple, if you take patients 6, 9, 10, 11, they actually decreased their pain intensity. They decreased their pain intensity, but they maybe didn't do so much of a change in number of body areas. But that's still like a decent amount of patients, and nice, like your bars kind of show this decrease like nicely. They're a little bit more nuanced too about some other patients that look like some outliers. And why did that happen? And obviously these are small numbers, so we're kind of extrapolating a little bit, but knowing these patients and having like further discussions after the session helped understand a little bit. So for example, patient 1, interesting, like pain intensity didn't change much, actually reported a couple increase in body areas, but they weren't too sure when they were circling it in the post. But what they really noticed is they actually like felt overall like better from like a sensory perspective. But they were quite relaxed in general. But what they did know is that it had been a while since like their opioid as well. So just keeping in mind that we still would give them like their medication. This didn't replace medications. And then looking at our patient number 3, so this is a younger patient on the younger age of the range that we said. Interestingly, those two outliers are like the oldest patient, so he was 25, and the younger patient. This patient was 6. That patient described actually, interestingly, increase in pain intensity, no change in body areas, but felt much better when we actually had to talk through the wording and like the experience of pain and circling words. And prompting a little bit more, like had some difficulty with actually like completing like independently when the words were like shown and we did that. She had some more difficulty with actually paying attention to the questions of following pain intensity and responding to that. One interesting thing to take into consideration, sorry, one patient actually scored a 0 on didn't feel like any pain when we asked number of body areas, didn't feel any pain when we talked about different measures of pain. But what was interesting is still had some pain intensity, but came down quite a bit. So that patient had some difficulty fully expressing where the pain was, what the location was. But what we noticed, apologize, this is what happens when I talk a lot. Give me a second. What we noticed was that she had a lot of anxiety and a lot of stress, and that came down really nicely with the VR session. This patient's also an older patient. This patient felt like made no difference whatsoever in any of the pain scores. But interestingly, that patient's level of like confidence and the even idea that it would help and the confidence in coming to the hospital at baseline was actually much lower, and in some ways had a little bit less of buy-in intuitively. Like they felt not worse, they didn't feel better, but didn't necessarily feel like at baseline, like they didn't feel in their initial assessment of do you think that might help, they didn't feel strongly about it. Also an older patient, so we have less of, I don't have like the data here to like show you, but the spread of the ages and that way of going through the questionnaires and appraising those scores does vary regarding like the ability to fully like participate and what the mindset at the time of the questionnaire is, which is like everything that would be a bias that's introduced in any other type of study where you would have similar type of assessments, but interesting. But overall, what was really nice is like when we looked at also satisfaction scores and side effects, we asked these very particular questions. Does your head hurt, your eyes hurt, upset stomach, dizziness? No side effects of VR. Most people felt like really fine with the side effects profile. And they also like really enjoyed just participating in using this. A lot of them felt that they would do it again if they were in pain. So that was actually really optimistic and hopeful. And that really helps us to think more about, you know, how we're going to expand this and enroll more patients. So we got the IRB and we really want to enroll more patients. I mean, I think we really would love to have larger sample size and data to sub-analyze and be able to publish more and share our personal experience from like Worcester and compared to the experience of other centers. We'd love to see like impact in some ways to medication and opioid use. But I think the bigger thing, and we started to see that a little bit with our dermatology clinics, is use in other clinical settings. And that's really encouraging as well that other areas of the hospital are picking up on this. So initially, we got a grant to actually fund our kind VR headsets and our subscription. And again, can't thank Simon enough. And it's been really nice. And I couldn't do this without our child life specialists and the nurse practitioners that work with me as well. So that's kind of with a few minutes to spare too. That's our experience with VR and pain management and sickle cell disease.